Hello, everyone. Hello, everyone. Good morning, good afternoon, and welcome to our endcoronavirus.org forum. Today, we are joined by three speakers that have worked on the front line of the Ebola outbreak of 2014 in West Africa. And you will have a chance to learn from them what the key lessons are from Ebola and how you can apply them to end COVID-19. We will be having time for questions, so you're more than welcome to send us your questions, put them on the comments if you're watching on Facebook Live, or if you're in the Zoom, you can leave them on the chat. Let's go ahead, and I'm gonna introduce our speakers, or actually I'm gonna ask them to introduce themselves. So let's start with you, Yaneer. Would you like to introduce yourself briefly?
I'm Yaneer Bar-Yam. I am the president of the New England Complex Systems Institute and the founder of End Coronavirus, and I was involved at the policy level in discussions of Ebola in West Africa.
Thank you. Thank you, Yaneer. Let's go ahead with one of our guests. Would you like to start, Sinead?
You have to unmute.
You're on mute.
There.
Okay.
Now.
Okay. Good afternoon. My name is Sinead Walsh. I'm currently the Deputy Director General for Irish Aid, and I think we'll talk today about my previous time in Sierra Leone.
Thank you. Thank you, and thank you for joining for this talk. Let's go with Oliver.
Hi everyone, my name is Oliver Johnson. So I'm originally from the UK, trained as a doctor, and have mostly worked in global health and health system strengthening, including a few years in Sierra Leone, which we're going to talk about. I'm currently actually dialing in from Johannesburg, where I'm now based. I'm doing a PhD on leadership in healthcare, and I've been a bit involved in the COVID response in the Gauteng province here in South Africa.
Thank you. Thank you all three for joining and taking time from your busy schedules. I think we're going to have a great discussion ahead. So please, if you have any questions, put them either on the comments or on the Zoom chat, and we'll have some time at the end to make those questions to the panelists. We're going to first start with a presentation from Sinead and Oliver about their time in Sierra Leone and the lessons learned from that. So the floor is yours.
Great. Well, I will kick off, and maybe you'll be glad to hear it's just photographs, no weighty PowerPoint slides, but essentially. Oliver and I wrote a book about our experiences in Sierra Leone called Getting to Zero, and we'd like to talk today about some of the lessons from that, which are of course very applicable to COVID, and I think it would be good to have that also discussion afterwards. So maybe just to kick off with the first slide, to give you a sense maybe of what we were both doing before the outbreak, and I suppose with COVID taking over international attention, memories of Ebola are probably a bit dim. So just a reminder, this was back in 2014. I had been in Sierra Leone already for about 3 years. I was the Irish ambassador and the head of Irish Aid in Sierra Leone and Liberia, and essentially working on lots of different things, nutrition, women's rights, education, and so on. And Oliver was working for the King's Sierra Leone Partnership, linked to King's College London, and focusing on health system strengthening in the country's main hospital. So very, very busy lives on very different things, and maybe the next slide gives you a bit of a sense of some of the challenges. So this is just a photo of one of the slums in Freetown, you know, and it is actually maybe quite striking to know that about 70% of the population of the city live in slums. So, you know, just to give you a sense of the enormous challenges that that were being faced before Ebola emerged. So we had a situation where about 1 in 5 children died before the age of 5. We had a situation where only 1 in 10 girls actually ever finished school. So huge challenges in that context. And then, as we'll see in the next slide, we started to hear of a mysterious disease which was raging through Guinea. So as you can see on the map there, you know, Guinea and Sierra Leone and Liberia are all you know, sharing a common border, and it was actually in if you see Kisadugu on the map, it was quite close to Kisadugu, where you had not just the first Ebola case in Guinea, but the first Ebola case ever in West Africa. So it was very much not a disease that was on any of our radars, but essentially we know now that an 18-month-old baby called Emile Mwamwano was most likely playing with bat droppings in a tree close to his house, and ended up being patient 0, and the disease then spread over a number of months through Guinea, and it took quite a long time to be diagnosed because it wasn't normally in West Africa. And initially, you know, in the first sort of 2 months after it was diagnosed in Guinea, we were kind of waiting for it in Sierra Leone, but it didn't come, and we thought maybe we would dodge a bullet, and we were actually facing a big food security crisis that summer, so we were really just hoping that somehow we would escape. But of course we didn't, and as you can see, you know, with the proximity of the different, you know, the different borders. In fact, the first case is very close to both the Sierra Leone and Liberia borders, so it did cross over, and Sierra Leone got its first case on the 25th of May. And I think Oliver will take it up a bit from there in terms of how that appeared in the country's main hospital.
Yes, so I was working at the main adult government hospital in downtown Freetown, the capital city, which is quite a big old colonial building with quite a few challenges in terms of staffing, in terms of the infrastructure, in terms of just supplies of things like running water and other things. So I'd been there for about just over a year, working with the hospital management, others on not doing clinical work. So my work was supposed to be very slow. How do we strengthen pathways in the hospital? How do we strengthen the medical school? And as Sinead mentioned, we started to hear about Ebola in Guinea. And actually, you know, the government responded very quickly initially. So the Minister of Health had been part of the response to cholera that happened in previous years, and so quite quickly put together a task force at the Ministry of Health with international NGOs and cross-government partners. And so there was a recognition earlier on that this could impact Sierra Leone in a serious way, not as serious as it did. I don't think any of us saw the scale of what was happening, but there were a lot of meetings, and I think part of the challenge in the early days is that we had a lot of meetings and there were a lot of things done on paper, but there was a huge disconnect between the plans that were being agreed in ministry offices and the WHO and the lived reality of what was going on at the front line. And this photo is of our dressing area and office in the Ebola unit we set up at the hospital. Initially, this was our Ebola unit. So we had 2 cholera beds in here, because we thought we would only ever need a couple of beds to isolate patients. And then in about May 2014, we got our first case, suspected case through the emergency department, then our second. And that evening we realized, and this was the evening in question, that we did not have enough beds. And so we had to massively scale up our unit. And so the head of the hospital, Dr. T.B. Kamara, shut down half of the emergency department, and we had literally 4 or 5 hours to put together an Ebola unit. So we went out to the local market to buy some plastic sheeting to wrap the mattresses in and put it up between the beds. We brought some fans, well, we got some buckets from the market, some chlorine. This is really what our Ebola unit consisted of, is things you could buy on the street outside. And we thought maybe worst case scenario in here, we will see 20, 30 Ebola cases in the course of the outbreak. In the end, in this room and the neighboring room, we saw over 1,000 patients, of which more than 750 tested positive of Ebola. And to give you context, the biggest previous outbreak, which had been in East Africa, Central East Africa, in Uganda in particular, the total recorded cases had been about 450 cases. And we saw more than 750 in this room. So it just gives you a sense of the extent to which this was just a different order of magnitude of what people had experienced, but also how those of us on the ground, none of whom were prepared for, I'm not an infectious diseases specialist, I wasn't working clinically, but really those of us on the ground had to quite quickly put something together to organize some kind of a response. Another thing we realized early on, very quickly our unit became full. We had 9 beds, we squeezed in 15 beds, we got it up to 23 beds, and then we couldn't fit in any more patients into our Ebola unit. And more patients started to collapse in the hospital outside of the Ebola unit, vomiting and prostrated, and more and more of our staff started to get sick and die. And in the end, we felt we had no choice but to build a tent outside of the hospital for excess patients to wait in until a bed became available. And so there were just queues of very sick patients outside the hospital waiting for a bed. And about this time, I went to the military hospital and found they had empty beds at the military hospital, and realized that this coordination issue was key, because one hospital was overflowing while another hospital had empty beds. And the country didn't have an ambulance system at that time or a coordination system. And so this is a colleague, a volunteer on the King's team, Amar Kamboz, and she put together with the district medical officer and his team a command center to try and coordinate across the city of Freetown. Where are their ambulances? Where are their beds? But if you look at the date, this is the 29th of September. So this was 6 months after the start of the outbreak. And you can see at the top there on the left, the isolation beds. So in Freetown, we had 5 isolation units, but between them, they only had about 45 beds. So 6 months into this outbreak, headlines around the world, we only had 45 beds in the capital city, most of which were being run by a British university in partnership with the Ministry of Health. And you can see here, available beds, 0, 0, 0, 0, 0. And this was our reality for months, that there simply were not beds available. Patients were stuck in their homes, quarantined with 14, 15 family members, no sanitation, there for weeks sick until a bed became available. And just as an aside, Amar, her background wasn't in medicine at all. She'd come out as a volunteer to help in a school, but her background was actually as a stage manager for West End musicals in London, most recently Wicked the Musical. But it actually turned out that her experience coordinating theatre productions was incredibly relevant to trying to coordinate across facilities and ambulances, because she had really strong logistic skills. And it's an example of how just medics like me weren't the right fit to solve a lot of these problems. We actually needed to bring expertise from all sorts of places. So at this point, I'll hand back to Sinead to pick up the story.
Yeah, so, I suppose I would have seen, I suppose, a huge shift in terms of my role, because essentially life became, all about Ebola. The other things that we were doing, came to a standstill. And really, as Oliver said, we just felt as though, the world was asleep. Even when we were in the headlines, as Oliver said, that didn't necessarily translate to too much, if anything, on the ground. And so I spent a lot of my time trying to kind of, bridge the gap between the sort of frontline workers and, kind of those working at the international level. So as you'll see from the next slide, eventually, I would say by about September, we got, VIPs like Samantha Power visiting. We had huge support from the British government, and things things did start to happen and resources did start to arrive. But bear in mind, our first case was in May, and really, I would say September was when we got a lot of pledges, but in reality it was October, November, even December when we started seeing treatment centers opening and so on. So it was a huge delay, and I think one of the things that Oliver and I sort of both realized and discussed kind of after the fact was that we both sort of had this idea in our minds in the early months that there would be a cavalry that would arrive, because we just assumed that this is what happened in these kind of situations, that people who really actually knew what they were doing would sort of swoop in and help out. And I think we very much realized that didn't happen. And even when we got a huge amount of resources from mostly the British government and to some extent the American government, what I then started to have to do with my time was actually help them adapt to the context in Sierra Leone, because you could be the world's greatest expert in epidemiology and so on, but of course the context was so incredibly specific, as every context is, and I think we'll talk more about this when it comes to community engagement. So a lot of my time then and others was spent on helping these huge international resources actually have a positive impact on the ground and adapt to the circumstances that they found themselves in. So if we look at the next slide, then we did eventually kind of get to zero, but it was at an enormous cost. So by the time Sierra Leone got to the end of the outbreak, we had 3,956 deaths, and I think one of the things really the whole idea of the book actually came from a conversation that Oliver and I had quite accidentally when we ran into each other one day about how we felt as though there was a lot of self-congratulations around when we sort of got to zero and so on. And to some extent, of course, it's something to celebrate, but we, I suppose, just experienced such enormous mistakes and failings, and we felt very uncomfortable with the notion of calling it a success story. And that's actually where the idea for the book came about, because we said, okay, well, if rather than sort of complaining that this is being seen too positively, if we should actually write about where we did see the mistakes, but also how things did turn around, because ultimately, even though it was very late, the response did turn around. The response did have a lot of positives to it. So that was really how we got together and wrote the book. And we'll just maybe to finish go through the 5 big lessons of the book. The first and by far the most important and the most significant is about community engagement. And I think what you can see in the photo here is how we started, wrongly, essentially, with the sort of loudspeaker kind of mentality. So, kind of giving instructions, rather than really kind of, sitting with communities and really figuring out kind of where they were, what was their starting point, and what kind of, how we can actually help them. So we started off, really quite on the wrong vein, very much about sort of providing information. Another failing, which is on the next slide, is very much a punitive approach that was taken by the government of Sierra Leone. Now, it was initially also taken in Liberia, and actually the comparing the two countries is extremely interesting, because Liberia started off taking a very punitive approach and putting, riot police on the streets and so on, when there were, and doing sort of forcible quarantines of people, which were sort of unheard of at the time, but I think people will be much more familiar with the word quarantine now. But Liberia actually realized, and the president of Liberia realized almost immediately that was completely backfiring, and so Liberia took a much more collaborative approach with between government and communities over time. Unfortunately, Sierra Leone never did that. So from the very beginning, it was a punitive approach in Sierra Leone. It was enforced quarantine of households, even of whole whole districts, enforced by the army and the police and so on. And really what this did was make people want to flee from the response, rather than want to actually kind of, admit. You wouldn't want to admit that your brother or your husband was sick, because then that meant you and your entire household would go into quarantine for 21 days. So you would definitely all lose whatever jobs you might have, because almost every job was casual labor. There weren't, very few people would have the luxury of having salary jobs and so on. So, what we didn't take a good enough account of in the beginning was, was people's circumstances. And I think the next slide is also on that point about empathy, which is sort of a related learning on community engagement. That, we had this situation. This is actually a quote from an MSF nurse, and she was talking about how you would have a mother go to one of these Ebola treatment centers, which were very fancy once they were set up and very well resourced, but if the child was negative for Ebola, then she would sort of be sent away, as if from a mother's perspective, as if she cares why her child is sick. I mean, she wants her child to be better. And it took us a long time. Eventually, with some really strong Sierra Leonean leadership, which Oliver will talk about later, we did manage to get a sort of free healthcare for any illness, which then started to improve the trust between the population and the response. But in the early days, we were very focused on Ebola per se. So eventually the community engagement did improve. We started supporting communities to come up with their own strategies, and then we started supporting them for whatever they needed to actually make their own strategies a reality, with the sort of epidemiologists more in the background and the sort of more anthropological discussions in the front. And I think that, this is something I know we will discuss more in the Q&A. So maybe we'll just run through the other lessons. I think the next one is about leadership and coordination. This was a key failing really in the early days of the response. The national leadership was very weak. The president, who's pictured there, it took a long time to visit the first areas where this was going on. They were opposition areas. I think that's also a really important part of the context as well, that there was these existing political dynamics, and of course the virus just comes and sits on top of that. It just exacerbates these political differences. It doesn't make them any better. And so initially the government really struggled to show political leadership, but eventually President Koroma really did turn it around. And that photo there is actually him with the local chiefs, and essentially he sort of basically told the local chiefs, this is the staff of power, you can kind of see there. And he basically said, any of you who are not showing leadership and who are flouting the rules and so on, I will take that staff away from you. So eventually that leadership did really improve. But also I think the international leadership, the US government played a very different US government played a very significant role, and that's just a photo of Barack Obama hugging the nurse from Texas after she recovered, which again was a real sort of anti-stigma moment, and stigma of course is another really important dynamic we can maybe come back to. So leadership and coordination started badly, got better, and that's also very related to the third lesson, which is about politics and accountability. And this is an area where, I think we wrote a lot about this because, corruption issues, politicking, both sort of at national level, at local level, and also with international organizations, was huge in the response. But what we found was that actually most of the time, when people are writing or speaking and so on, it's almost taboo to talk about those kinds of things. It's not kind of politically correct, but we really wanted to talk about them because they did dominate our lives, whether it was, somebody's, a government official saying, no, we won't set up that treatment center unless the NGO gives us $5,000. That happened to one of my friends. Or whether it was, international organizations also playing politics with the response and rivalry between different, UN agencies and so on and so forth. All these kinds of issues really were big barriers. And so we go into some detail on those as well. And I think Oliver will talk about the last two lessons.
Yeah, and so just picking on this one, it's interesting. I spent 3 months volunteering with the war room of the COVID response here in Gauteng province, which is where Johannesburg and Pretoria are. You know, and we have seen very publicly in the media now a repeat of those same issues. The provincial minister of health has been suspended, accused of corruption. Yesterday, the provincial head of department for health resigned because of accusations of corruption around tenders for protective equipment, political favors, these sorts of things. So it is quite striking, and for me, I think I find it incredibly depressing to be back in the same situation where we've got a big enough fight ahead of us just to deal with the technical elements of this virus, and yet we seem to be bogged down in so many issues around both kind of taking political advantage, ideological advantage, but also the money involved in a response like this and how it's channeled. The fourth issue was around working through government systems. So I think particularly in somewhere like Sierra Leone, where you know, a lot of the response was channeled, international response was channeled through NGOs, mostly foreign NGOs. And some of that was to do with capacity, some of it was around trust because of those corruption issues. But there was a tendency to do what you see on the left, and this is Kerrytown, which was an Ebola treatment center that was the so-called crown jewel of the British response in Sierra Leone, built and run jointly by the British Army and Save the Children. But you can see it was an entirely new complex that they carved out of the bush, had to put in roads, put in electricity, and build new structures. But this was how a lot of the response was done, flying in new vehicles, building new facilities, and it took an incredibly long time. So you see the timing here. You know, the first discussion about the British running Kerrytown was the 12th of August, but it was 4 months before it admitted its first patient. And 4 months in an outbreak is you cannot wait 4 months because you are chasing an exponential curve. And so that instinct of the international community to build their own structures and to do everything meant it took a lot longer, often was much more remote from the communities that these facilities were supposed to serve, and was incredibly expensive. And this is the point of comparison. So this is one of the facilities we opened. We were asked to help the government open this facility on a Sunday, on the 24th of October. We admitted our first patient on the 31st of October, so 7 days later. And that was because we went into an existing hospital with existing staff and an existing supply chain. And we said, okay, what do we need to adapt together to set up an Ebola unit in this space? And some of the facilities we were able to set up, particularly the one at my hospital, we were able to build a permanent infectious disease department. So right now, the COVID unit of that hospital is the legacy Ebola unit that we built during the Ebola outbreak, very deliberately, because we said there will be future outbreaks, be it cholera or be it an influenza or something else. And the legacy during this outbreak within the health system, with staff that are trained, that are used to working there with supply chain. The BBC, a couple of years after Kerrytown closed, went back to that facility on the left and described it as occupied only by goats. So you have this huge, slow building of infrastructure that often can't be sustained, whereas I think a different approach could lead to something that's both quicker, more community-owned, and more sustainable. And I think our final point is just about the importance that individuals played in shaping the response, both at the political level, but also at the operational level. And this could be positive and negative. There were people who, both in the international community, but also in the Sierra Leone government and elsewhere, who often blocked or obstructed the response or simply didn't have the capacity. Similarly, there were individuals who were remarkable, and the work that they did completely shaped how things developed, and often they came from unlikely places. So the lady here, Yvonne Akisoya, was at the time a businesswoman based in London. She flew out during the outbreak and said, look, I want to contribute to this response. I'm not a doctor, but I want to contribute. And was made director of planning for the response. And she played a critical role in re-exerting Sierra Leonean leadership of the Sierra Leonean response rather than just foreign leadership. But also saying we need to listen to communities. So she would go for hours where there was a cluster of cases to listen to what community members had to say. She would spend 5-6 hours in some of those slums, listening, getting the community on board, adapting the response to be much more community owned. And she's now been elected mayor of Freetown and has done a superb job in helping to reshape the city and set political direction. And so I just wanted to, before we wrap up, and this is Yvonne with the book at our launch with Sinead, so she's been very supportive. we were going to open up discussion, but I wanted to make some kind of final reflections at this stage on, I think, some lessons from Ebola that are relevant to COVID. You know, I think one of the things that was a real challenge in the Ebola response is we never completely understood the transmission dynamics. We had theories about where and how Ebola was being spread. Was it at funerals? Was it in hospitals? But very rarely did we really understand exactly, was it physically touching a sick person? Was it sharing kitchen utensils? Was it to do with sewage and sanitation? How was it, in a very technical sense, Ebola was being transmitted? And we never fully got to the bottom of what was driving the outbreak. And without knowing what drives the outbreak, you can't design your response to stop that transmission. You can't give the best advice on behavior change. And I think it's remarkable that with COVID, we're still asking whether or not COVID is aerosolized or whether it's droplet transmission. And we have the most advanced science on vaccine technologies and on monoclonal antibodies and all sorts, but we cannot answer the question of actually what are the mechanisms of transmission of COVID. And I think that's really critical and something we need to be better at. And I think one of the reasons we're possibly so bad at it is because it's such an interdisciplinary area of research. Because doctors alone don't know how to answer that question. They need people who understand chemical properties, they need people who understand aerodynamics, they need people who understand fluid dynamics. And so I think that's a particular reason why that's been a challenge. A second point is about models, and there was a lot of modeling in the Ebola response. A lot of the models were wrong, and I think of George Box's quote about how all models are wrong, but some models are useful. And I think one of the dangers of an outbreak is there's so much uncertainty that political leaders will often grab hold of a model as if it's a prediction of the future. They will see a model like a crystal ball and not realize that a model is simply a projection of one possibility based on certain assumptions and policy, directions that could take place. And I think getting a better public understanding of what models are and scientists being better at being careful at how their models are used is very important. Because otherwise, I think policymakers can take models and run in quite dangerous directions. You know, interestingly, the US CDC model that if the outbreak didn't rapidly and significantly improve, which it did, but if it hadn't improved, there might be over 1 million cases of Ebola in Sierra Leone and Liberia. And of course, that model was way off. It was a way overestimate of the number of cases. But it was useful because that model scared the world into massively deploying more resources, and that saved many lives. So I think asking yourself not whether a model is right or wrong, but whether a model is useful is important. I think a third comment is how much social media was critical. In Sierra Leone, most communities had access to phones, to WhatsApp groups, to Facebook, and most information was being shared very rapidly by social media. And I think the public health community was still very much playing catch up with how the world had changed over the previous decade. And I think we need to really rethink about how much we're engaging with the role that social media plays in outbreaks. And finally, I want to kind of end on a quote from Mike Ryan, who is head of emergency responses at the WHO, one of the 3 leaders of the WHO for the COVID response, who says, "The virus will get you if you don't move quickly. An outbreak response is a race against time." And what he says is, don't let the best be the enemy of the good. And I think that point is so critical that in an outbreak, you need to move quickly and you will have uncertainty and you will make mistakes, but you must move quickly in an outbreak because every day you're seeing an exponential increase. And so speed and flexibility and a willingness to make mistakes, I think, in an outbreak response are all essential, because if you wait till you've got everything perfect, then you've waited too long. So I think those are some of the lessons that we wanted to draw out from the Ebola response relevant to COVID. And I don't know, Sinead, if you wanted to add anything else before we hand over to Yaneer to pick up. I think you're on mute, Sinead.
I was muted there. I just wanted to mention a couple of things, because I have spent most of the COVID period in South Sudan up to about a month ago, and I think some of the some of the issues. South Sudan, of course, would be even poorer again, and I think some of our lessons were really kind of highlighted there. One which maybe we haven't touched on yet is about the secondary impacts. So we lost more people during the Ebola crisis from other diseases. So it was because of Ebola, in the sense that, because they couldn't get their HIV treatment, or they couldn't get their malaria treatment, and so on. But they didn't die of Ebola. But essentially, they died because the health system shut down. So I think that was something that really was something we were very, very alert to in South Sudan. I think we managed to avoid that. There was several of us in South Sudan who had worked on Ebola, so we were all sort of pushing on that. But I think an area where we did worse in South Sudan, even though we knew about it, was this whole lesson of balancing COVID prevention with like the massive food security problems that we have, for example. So there was a whole load of restrictions and travel restrictions put in for COVID, which really had a negative impact on the ability of humanitarians to actually function in the food security crisis. And things have, there were some improvements in the last 3 weeks or so, but this was an area where, possibly because COVID was all over the world and it was in the media all the time and all that kind of thing, the politicians were more inclined to sort of focus on COVID measures and less inclined to recognize the negative side effects of some of those measures. So that was a big issue. And finally, maybe the cost of prevention. This is obviously something that we talk about in all of our countries, but obviously in a country like South Sudan, it can literally be life or death if lockdown measures are set up, and restaurants close and so on. There's a whole load of people cleaning, people sweeping, people carrying things from one place to each other, really, as in Sierra Leone, very, very casual labor that are suddenly kind of left asunder. So these were some of the things we were trying to work on. And I suppose just related to that, is kind of related to what I said earlier. The costs of things like masks for some of these people with these very, very menial jobs and tiny salaries. I mean, the cost of a mask is so disproportionate, and the notion of sort of telling everybody to wash their hands all the time in a place where most people don't have running water. So it was a lot of the same themes. Maybe some of them were even more accentuated, and so we were kind of battling the same issues with COVID, and to some extent that does continue in South Sudan. Thanks.
Yeah, thank you very much, Sinead and Oliver. I want to switch it over to Yaneer now, and maybe you can tell us. I think you were on the other side of the Atlantic warning the world about Ebola. So what are your thoughts, Yaneer?
Sure. So let me share a little bit about sort of the perspective that I had on what was going on. And first of all, I had warned about much larger Ebola outbreaks. In fact, I was at WHO in January of that year, and I gave a presentation which had a 5-minute section in it where I basically said, I explained that increasing global transportation was going to cause much larger outbreaks, including of Ebola. And you could see the jaws drop in the room. But nothing was done, obviously, in terms of preparation. And the point is that people consistently think about the future in terms of past experience. And scientifically, this is the method of statistics. So, so it was very hard to overcome. And it's not that they weren't respectful of the work that I'd done. There was a lot of respect, but to take action based upon a warning that you haven't seen something happen is very hard for people to do. And of course, a couple of months later, the outbreak started. And by the summer, it had gotten out of control, and I started to get involved at a policy level. So I was interacting with the head of the UN response. David Nabarro at the time was head of the response, and I knew him from earlier work because he was involved in food security, and I had been working on that as well. I was involved with the National Security Council and with the CDC because of other work that I'd been doing. But when it got out of control, the analysis that we can do with the mathematics that I understand is that once your approach fails at an individual level, you have to go up to the community level. So the individual level approach was people would show up in a hospital bleeding, and then they would try to stop the outbreak by identifying close contacts in the community. It's called contact tracing, which we know from what's going on now. If you have one or two or a few cases in a rural area, then you can do that, maybe 10. But if you have 100 cases, there's no way, not even 10 cases in an urban area, there's no way you're going to be able to find all of the people that are connected. So it's impossible to stop an outbreak like that. So all of the mathematical models, as was discussed, were predicting 1 million, 2 million people by January of the next year. Really what they were saying was that there was going to be burnout, that there was going to be no way to stop the outbreak, and burnout would have meant 10 million people dead. And those were the projections. And I talked with colleagues and they say, no, you can't change human behavior. There's no way that it's going to change. And there were assumptions about the fact that it wouldn't spread to the rest of the world, which were also not true. So all of this assumptions built into mathematical models informing policies was a failed part of the understanding, with the exception, as was mentioned, that by having catastrophic outcomes, there were people who were taking it seriously. But the serious response was not going to have any kind of impact on the outcome, except for more medical care, perhaps, or somewhat more medical care, but it wasn't going to stop the outbreak. So I tried to get people to adopt a different approach, which was a community level response, which you would send people into the community to engage in the community and to identify cases early and to stop the outbreak. And I worked with the various organizations that I knew and tried to get it up, but the government was not able to move fast. We've heard that before in multiple ways and experience it today. And I had a friend, Catherine Collins, who was involved in a NGO in Liberia on the ground and doing health work. And I called people there and they put me in touch with people who were on the ground working on Ebola. Middle of October, I called them up and I said, you know, how are things going? And they talked to me about what they were doing. And I said, well, what about doing this? And they said, oh yeah, we started doing that 3 weeks ago. And what they had done was to start members of the community going door to door. And this was better than what I had thought of course. They went door to door, identified early fever, and isolated people immediately upon early symptoms, whether or not it was Ebola or not, because the symptoms are generic at that point in time. And that process, we've done modeling, we've done analysis. There's no other model or representation that is explaining the stop of the outbreak. It went up exponentially, it went down exponentially. The point of the switch of behavior was mid-September, when they started to do the door-to-door monitoring. It took 3 months for that to be transferred to Sierra Leone successfully. It was done as part of much more government-driven effort than it was done in Liberia, but it was nevertheless transferred over and stopped the outbreak in Sierra Leone. So from my perspective, we learned 2 different things. Number one, in fact, it is possible to stop an outbreak, which again was denied by a lot of the modeling efforts and the people who were doing them. And the second is that it's really about the community taking ownership of its own health and being responsible for making it happen. Of course, it can be done in collaboration with the government, and that's the best. It can be somewhat done by government imposing things, but of course, the best thing is when the community takes responsibility and it's supported by the government in doing so, and that's the big success. So those were the lessons that I learned.
Yeah, thank you very much, Yaneer. That's so it seems like from the top as well, there was a different response in Liberia and Sierra Leone. So perhaps that punitive approach did not welcome that community engagement that much. I don't know
But it was important, the community engagement was important everywhere. It was important in Liberia, it was important in Sierra Leone, it was important in Guinea. It happened in slightly different ways in different places because the communities are different and the authorities are different, but it is truly essential to what's happening.
Right. I want to remind our viewers that we're gonna receive questions. So if you have any questions you want to make to the panelists, write them either on the Facebook comments or here on the Zoom chat. I don't know, Oliver, or Sinead, if you had any other thoughts you wanted to share.
I mean, maybe just picking up on that point about the punitive approach. I mean, it was really interesting what happened in Liberia, because there was a center, a sort of an isolation center set up in a slum called West Point in July of 2014. Really at the height, I mean, absolutely catastrophic stage of the outbreak. I mean, MSF at that time were, running their biggest ever Ebola treatment center, and they literally said we had 60 seconds per patient. That was all. I mean, they were just so incredibly overloaded. I mean, people were just dying at the gates. So it was a horrendous time, and the government set up an isolation unit because there was a lot of cases that came up in West Point slum. And, so they had sort of slum residents who were seen to probably have Ebola isolated in here. And the wider community just, really, were horrified about this, and they stormed the center. And they didn't believe that Ebola existed, and they stormed the center to the extent that they even took away, mattresses that were bloodstained and all that kind of thing. So you can just imagine how much that would have magnified the infection. But I think the point was that nobody had spoken to them about setting up this center. So, it's also that the notion of a punitive approach is that people are deliberately kind of not following instructions, or they're deliberately sort of being rebellious and so on, whereas so much of the time in Sierra Leone and Liberia, there was, and also in Guinea, there was fear and there was misunderstanding, and things had never actually been explained to people properly. So when it ended up happening then was that immediately after that sort of riot within that center, and the center was emptied and all the patients were taken away, then the government sort of brought in the riot police, and there's 250,000 people in this slum. They brought in the riot police, and they said, okay, we're going to lock down this slum for 14 days. And then they just realized this is madness. I mean, they realized themselves, this is crazy, this is never going to work. And so they actually stopped that quarantine after 3 days. And the president herself, went on the TV, went on the radio, and she said, we made a mistake. We need to be doing this with the communities, not against them. So I think this is part of the problem with the punitive approaches, is that they often assumed the wrong thing. And, as Yaneer was saying, when the approach was changed, which happened later in Sierra Leone, as he said, all of a sudden, when people were actually respected, and when people sat down with them and really took the time to go through all the different rumors and conspiracies and so on, and actually, really explain and so on, there was a transformation of behavior, because it was a transformation of understanding, and people started saying, oh, you're actually here to help me, you're not here to sort of lock me up and all that kind of thing. So I think obviously real lessons also for COVID. I mean, you obviously can't have a free-for-all. I mean, by definition, an infectious disease crisis requires restrictions of movements, right? We can't change that, but I think it's so much about how that's done, and that's really a big lesson that we learned.
And just building on that, one of the things that the mayor of Freetown, Yvonne Akisoya, called us out on a bit when we did our book launch in Freetown, and she said, I wish you would stop talking about community engagement and talk more about community ownership. And I think it's actually a very important distinction, because when I think back to the early stages of the Ebola outbreak, when I sat in ministry, the Minister of Health would ask one of her directors to call in all of the Market Women's Association, or the Taxi Drivers Association, or the Imams and the Christian Leaders Association, and they'd haul them into a conference room and they'd say to them, you must wash your hands with bleach between every person, and Ebola is real, and now go and do these things. And then they pushed them out the door, and they ticked a box, and they said, these people have been engaged. They've been engaged. And it saw engagement as a completely process-driven thing of a tick box exercise of, well, we sent them some leaflets and we told them what to do. So I think the language of community engagement, particularly to bureaucrats in ministries of health, often in countries which are very grant donor-driven, where they're quite used to having to meet certain conditions, I think framed it in a bit of a top-down way, whereas I think community ownership can only be achieved when the community genuinely feels that they own the response. So I think using that as your metric of, does the community feel like they own this response rather than did we engage them, kind of forces you to go a little bit beyond the usual megaphone tick box approach. Another couple of things that just add from what Yaneer said, I think there was something really important what he was saying about how WHO early on may have heard and believed his concerns about much larger outbreaks due to global transformation. But it is so hard, I think, to prepare or even conceptually understand something that is unexpected and unprecedented. And I think one of the dangers that we saw after Ebola is everyone started saying, okay, what are the lessons for the next Ebola outbreak? And I think one of the things I was saying then is we shouldn't be preparing for the next Ebola outbreak. We know how to do Ebola now. We should be preparing for the next completely unexpected, unprecedented thing that isn't Ebola, because that's what got us. It wasn't because Ebola was particularly complex or tricky. It was just because we'd never dealt with this thing before, and it took us longer than it should have done to realize that our assumptions were wrong, to realize we needed to do things differently. And I think it's really important that as we learn from COVID again, we don't just come up with the best possible model for a future COVID outbreak, but we've got to prepare for something else that's different to COVID, that's unexpected. So building in that ability to deal with uncertainty, to deal flexibly, and have kind of core assets that you can deploy in a more flexible way. One of the things that came out of the Ebola outbreak is Gates and other people were designing the perfect suit to deal with Ebola. It was a one zip piece suit. And I remember sitting there looking at the design saying, this is beautiful Ebola, but if the next disease is airborne, this suit isn't going to help you because it's not designed for airborne transmission. And so you're going to have tens of thousands of these things sitting in a warehouse. But they've been over-designed for a very specific thing. And I think trying to understand what are our core assets that we need to respond flexibly. And a lot of that is about kind of leadership. A lot of it is about kind of broader management leadership capacities in government. But a huge one is trust. And I think where there is pre-existing trust between communities and the government, and between health workers and the government, health workers and communities, and the international community, that asset of trust then allows you to go in in a much stronger place to try and build that community ownership and co-design a response. But where there is mistrust, where there is divide, and where there is tension, you are starting with a huge deficit. And to try and build trust in a crisis is virtually, it's not impossible, it's incredibly challenging to build trust in a crisis. And so I think all those, understanding what are the real assets to an outbreak response and understanding them with things like trust, I think is really important.
So I just would second Oliver's and Sinead's, or third, their discussion. And after Liberia, I also had experience in the Congo with colleagues, and we built our own community-based response in the east of Congo. The reason why we did that was because the lesson was not learned and not transferred of the importance of this community ownership statement. And that in fact, the humanitarian organizations, I was involved there in consultation with them, would say to me, well, how do we get them to do what we tell them? And my answer was, did you ask? And none of them were in the mode of, they were all with the megaphones like you described it, but they were not asking the community. They were doing polls to find out what were the attitudes, but they weren't talking with people. So we actually worked to build a community effort based in the church in East Congo that is strong there, the Catholic Church. And the first thing that they did is they engaged with the community and had a conversation about what was it from their perspective. And of course, we knew some of it because the humanitarian organizations, because of conflict there, were going in with convoys and armor and so on. So they didn't come across very well in a community context. And the second thing about the building of trust and the fact that the engineering for a particular scenario is not effective is super important because, and again, thinking through what are the set of things that we have to address rather than focusing on a particular scenario is really important. And that's within a disease, right? Dealing with the local community. What is the circumstance here as opposed to the generic circumstance is important. And of course, what is important in disease going forward? I totally agree with your statement and the importance of.
And I think just adding to that, I think, I felt, I had various moments writing the book and afterwards of kind of guilt and remorse, looking back on things that, we should have done differently. And I think I really recognized that as a health profession, I was very used to focusing on the confines of my health facility, especially as I was focused more on hospital care. I think primary care doctors often get more out into the community, but this was very much driven from a secondary care, infectious disease, clinical direction, where we are exceptions, but often we don't do that well. And I thought, well, really my priorities are, do we have enough body bags and enough chlorine, and is our staff training enough, and what are the processes? And by the time I'd done that, there wasn't any time in the day for me to say, actually, have I sat down with the community next to our hospital and asked them what they think about Ebola unit and asked them what they think is going on? And at the time I thought, I don't have time to do that. I'd love to do it. I think it's important. It's a nice to have. But because of all these other logistical things about the ambulance that's broken down and the nurse that's sick and the queue of very sick people, I can't do it. And what I now realize is I didn't have time not to do that. And what was incredibly difficult, I think, when you're faced with all of these very logistical, technical challenges in front of you, is to put them to one side and say, actually, it's more important that I spend my morning out listening to what the community has to say than it is to deal with the fact that we've run out of chlorine. It's very hard to do that because the chlorine is so much more immediate a challenge. And that cuts across to policymakers, it cuts across to resourcing. But I think so often what happens, although people say, yes, we know community engagement is very important, it always seems to fall to the bottom of the list. And, I think of an example of when I worked engaged a little bit with the WHO response in the Eastern DRC when there was the outbreak there, because I was in a discussion about going out to support the response. And the WHO shared their organogram for their response team. And they said, look, we've really learned the lesson from Ebola. But I looked at their organogram and it was a medical lead and a nurse lead and an infection control nurse and an epidemiologist. And I said, but nobody here is engaging the community. Surely that's the biggest lesson, is that someone on this team at this hospital in a senior role needs to be leading that, be an anthropologist or just someone who has skills and experience with engaging communities. And they said, we'd love to, but we didn't have the funding and we don't have the capacity, so it hasn't made the list. And so somehow we keep seeming to make the same mistake because the tangible always surfaces to the top. And the more intangible, the more important, ends up last on the to-do list, last on the organogram. And therefore I think we're stuck in that cycle. And it's a psychological shift to prioritize the intangible that I think is so important.
Thank you for saying that. Super important.
Yeah. I'm wondering. Is it like communities need permission to lead? Like, what is lacking? I think like both Oliver and Sinead, as people from authorities, either in the health response or the diplomatic response, you feel like communities need to be approached from the top down. But something we're seeing in coronavirus.org is like communities can give themselves permission. They can tell themselves that, well, but it's really hard. And we're trying to do some community engagement here in Costa Rica. For me, I find it difficult to people to break that paradigm of like, we need permission from the government or from the health authority. So how do we navigate that? How can we allow communities to tell themselves that they can to respond to an epidemic. What are your thoughts on that?
I might say something and then I'll let others comment. I just think it's been interesting here in Cape Town in South Africa. There's been a really significant and successful effort for community-driven responses. And actually, a key person in that is a South African doctor who volunteered on my team in Sierra Leone, saw all of this play out in Sierra Leone, was back working in Cape Town at the start of COVID, and immediately said, okay, I'm going to try and implement what we kind of learnt there. And so in Cape Town, they have a network called Cape Town Together. And it's very much individual communities setting up their own community action network, or CANs. And these CANs are very much driven by kind of not by health professionals, but by different members of the community. And they have identified their own priorities, be it actually the kids are not in school and they're not getting food because they're missing the free school meals, so we're going to do a community food kitchen. Or we've identified that there's a really high risk activity, a taxi rank in our community or a shopping area. So we're going to go out and we're going to work on, social distancing and other things. I think there's a few things. I think part of it is, as you say, I think a lot of people in the communities feel that they're not qualified. They don't know enough about epidemiology and transmission dynamics. They don't want to do more harm than good. And to some extent, I think there's some truth in that. We also don't want everyone just coming out of the woodwork and doing whatever they want and without understanding, what's effective. But this is where this coming together, and that Paul Richards' quote earlier of epidemiologists needing to think like community members thinking like epidemiologists. I think there does need to be a coming together of some technical expertise with community expertise in a joint effort, so that the two are together. Because I think, so that's one thing is I think health professionals, people with expertise, need to make themselves available to and collaborate with those communities to help them to think through what will be effective. But I think, as you say, the other thing is that I think ministries of health or local governments, need to leave the door ajar for the communities to come through. And I think what's interesting in Cape Town is, from what I'm told, is there was initially quite a positive reaction to these community action networks. And the Department of Health held Zoom meetings with all of these networks to listen to what they were doing and to share information. But then at a certain point, that community leadership started to look quite threatening to political parties, because they started to see communities get organized and start to say, why are we doing this just about COVID? Why aren't we doing this about other issues, about, the roads not working and corruption and other things? And suddenly, there was a shift, and that's where the politics comes on board, where I think people started to see that as slightly threatening. So I think those are some of the dynamics that play out. But I think we don't do enough to share good examples of where this is working around the world. So finding great examples, I've heard great stories in Vietnam, there's some from Cape Town, I'm sure some Costa Rica, elsewhere. Getting those platforms out of what people are doing could be really inspiring, and encourage others to do the same.
Right, thank you. And I guess that coming together it can be a bit difficult in any epidemic. And I guess this is a question for Sinead. So I read in your book, you talk about bringing people on the front line, like Oliver, doctors like Oliver, and people in the NGOs, the donors, trying to bring them together. You innovated with this very creative solution I found, that you were doing what you called balcony diplomacy. So you would bring people to your apartment, and you would, you mentioned in the book there wasn't much more to do in Freetown. So you would bring people together and have them mingle. And of course, I don't know if you had any thoughts on how we could do that in the COVID-19 era. So like what can we do to bring people together so that we can get that community action moving? If you had any thoughts on that.
Yeah, no, it's really tricky. I noticed there's some really good questions on the chat as well, about these topics. But I mean, just on that one, I mean, I did try to do the same kind of thing on COVID. The problem in South Sudan, the problem with COVID, of course, is that it's so much more infectious than Ebola. So, really your options of physically getting people together are radically reduced with COVID vis-a-vis Ebola, where, you know, really the main people who were getting it were sort of, you know, carers for the most part, healthcare workers and families, whereas for COVID, I don't need to tell anybody. So I think what we did start off, you know, I had a sort of a group of, you know, kind of humanitarians, and, you know, one or two diplomats that I worked very closely with, and then we would try to, you know, behind the scenes kind of, you know, come up with points that we agreed, and then people like me would bring them to government, but a lot of that had to move to WhatsApp, because we really stopped being able to meet physically once we had the virus, you know, transmitting in Juba, which was maybe a little bit later than in a lot of other places. But I think, look, it's always possible. You will have different kinds of constraints, but I think, you know, the point is that, you know, in you know, in countries like South Sudan, if we as diplomats are not talking to you know, the frontline workers like those of MSF, there was also a citizens task force that was set up, which is probably the only thing I could think of that has maybe some relationship to the examples Oliver talked about in South Africa. So I also kind of simultaneously worked really closely with them. But I will say that this is super context specific. There were very compared to what I hear about in South Africa, you know, there were very few kind of citizens driven initiatives in South Sudan, and I think a lot of that comes down to resources. I mean, just a lot of people in South Sudan are just trying to get through the day. There isn't a strong civil society tradition. It's you know, country that has come out of war, that is still struggling with conflict, and is sort of more a militaristic society. So I think that the civil society tradition is certainly not as strong there as in other places, but it can be supported. And I think this is why we were trying to work with the Citizens Task Force, much as it was a relatively elite kind of middle class group of, you know, the normal kind of NGO types, but it was still a start, and they were trying to engage at local level as much as they could. So I think it's really about trying to kind of foster whatever is there, but every context will look very, very different. And in South Sudan, you know, resources was, you know, is always, you know, very much there. I mean, when you've got you know, more than half of the population you know, in some level of food crisis, from kind of, you know, what's called crisis level on the international scale and what's called catastrophe level on the international scale, more than half the population are in that, you know, at least at crisis level. So that is such a core, that's such a core factor for anything that you want to do, is even time. You know, if you want time to sort of talk to people about the disease and all that kind of thing, you really have to take into account what else they need to be doing, you know, just to get through the day. So I think it's yeah, it was trickier, but I think we managed to do it, and I think we very much had to move to virtual means, which isn't as you know, it's not as good, it never will be, but look, it was certainly still reasonably successful, I would say.
So WhatsApp, Zoom, and so on, not everyone has even a phone or a computer, but that's the means that one has.
Right.
Yeah, we didn't really, I mean, we wouldn't have good enough bandwidth for things like Zoom, so it was very much WhatsApp, and as I said, we weren't really reaching people, you know, sort of at the community level anyway. That was part of our problem. I mean, even the Citizens Task Force was largely that, you know, sort of small kind of, you know, it was led by the kind of middle class and so on, who did have the phones and so on. So that's why we could use that. But of course, if we really managed to get down to the ground level, which the Citizens Task Force were trying to do, but obviously it was difficult for them, then you know, obviously those virtual means are quite elite. But even us as internationals, we would rarely have good enough internet to do, you know, really the sort of Zoom things that you can do in other countries.
Let's go to the questions, maybe, Thomas.
Yeah, I just wanted to put a plug in there that at endcoronavirus.org, I guess our way of solving this issue, or a creative solution we found, is we have Zoomy social calls. So if you're in the American continent, you can join just a social call. We do it at 9:30 p.m. Eastern time. Or Yaneer, can you remind me what the time is for the international call where people can come together? And
11 Eastern time on a couple of days, but I think Wednesday is the day that it is that I remember.
Right. So if you're interested and maybe you're lost in how to start a community engagement, this is a great opportunity. So daily at 9:30 p.m. Eastern time, or on Wednesdays at 11 a.m. Eastern time. And there's a question from Matti on the Zoom, and he's wondering what really is a community in an urban setting where people don't know each other in their neighborhood, and how do I define my community? Would it be like my sport club or workplace? Yeah, that's the question from Matti.
I'd like to come in on that one. I think it's such an interesting and important question, and it so builds on what we were just saying. And, you know, just to build on what Sinead and Yaneer were saying, I think we need these structures of community leadership of the healthcare in an outbreak, but we need them all the time. If we want to tackle obesity and diabetes and drug abuse and all sorts of other issues, we need a community-led response. This is what healthcare should look like anyway. So actually, I think this speaks to like a bigger transition that healthcare, which has always been quite institutionalized by professionals in hospitals, you know, it needs to be rethought. And we've been saying this since the 1970s, you know, the 78 Alma Ata Declaration, the WHO, UNICEF did, saying we need community-led healthcare, strong community-led healthcare. And so I think these structures we should be building not just for outbreaks, but all of the time. There's a fantastic book called Health is Made at Home, Hospitals for Repairs, by a guy called Nigel Crisp in the UK, who's really picked up this idea of health creation. So looking at the places in our communities, be it an urban food farm or a neighborhood society that are actually generating healthy behaviors in communities, and how that's far more important than the work doctors do for repairs when people have broken themselves one way or another. So I think this is the challenge, and I think globalization, urbanization, increasing secularization, a lot of the structures that existed before for community, like, you know, if I think of the UK, you know, the village church on a Sunday was a very important town hall event, a social event, and those churches are largely empty now in the UK. Massive urbanization, you know, with people working and going to school so far away. So I think these are huge questions. I think you do need to, one of the things I was pushing for the Johannesburg government to do is to say, you need to map your community assets, and they're going to be different in every community. So if you go to a township, you know, ask yourself, who in this community is trusted? It might be a barman in the local bar who knows everybody and is trusted. It might be the clinic, it might be a politician, it might be a traditional healer, it might be a celebrity or a footballer, but you've got to map out in your particular communities, and it's going to vary. You know, and as you say, it could be sports club, it could be other things. But I think, you know, as a bizarre aside, I just recently opened a restaurant in Johannesburg. And the reason I've done this is because I couldn't find a place of community for where I've lived in inner city Joburg for the last 4 years. And I thought any effort to improve community organizing has got to start with some kind of a space where we can get together and get to know each other and build trust. And out of that, we can start to do activism against corruption. We can start to go door to door on healthcare, but we need to start building structures. I think another thing that Sub-Saharan Africa is ahead of the curve on, as well as parts of South America, Southeast Asia, is a lot more community health workers. So in South Africa, they've got, you know, people who are assigned a street or a set of streets in their community as lay health workers, and their job is to go door to door, to get to know everybody in every house, and to find out, have you had your blood pressure checked recently? Is anyone here pregnant? Have they gone for antenatal care? When did you last have your HIV test? And the idea is that these community health workers will build relationships with 3-4 streets, know everyone on first names terms, and those ought to be the kinds of structures that exist so that when an outbreak happens, those people who have the trust can go out and engage. And I think those are the sorts of things about how healthcare needs to be restructured that we need, because once a crisis happens, to build these structures from scratch is very, very challenging.
Perfect.
Yeah, there's a question from Nikki on the Zoom chat. She's asking that in a seminar for the New York Academy of Medicine, it was recently suggested for doctors to talk more casually, to chat casually with patients. And they mentioned that there's a lack of trust from African Americans to doctors, and that is resulting in a higher death rate because patients are coming to the ER late. I guess, Oliver, and also talking about social media, so I see a lot of millennial doctors from Costa Rica. They're posting on Twitter, like, I bet a lot of doctors are overwhelmed. So it's not to put the burden on them, but what do you suggest for doctors, and how can they spark? A lot of them are using social media to share, like, please take care of yourselves, like my ICU is full, or do you have any thoughts for that?
I think it's really interesting. I think part of it speaks to the kind of health workers we train, and historically it's been a very white male elite profession, and I think we have seen more diversity, particularly across the board, but including with doctors, but not enough. And I think it's important that doctors represent, in terms of gender, race, social, economic background, and religion, other things, the communities they serve, and a part of the communities they serve. Somewhere like South Africa, it's a huge problem because we still have a hugely disproportionate number of white South African doctors being trained in a country that's 85% black. Black communities mostly speak Zulu as their first languages or other languages. There's all sorts of barriers, cultural barriers, language barriers, historical barriers that make it very difficult for those that kind of understanding and those bonds of trust. So I think it partly talks about, what is the health workforce that we are training in the first place, and how much are they an elite academic group, and how much do you need to be an elite academic to be a good doctor, versus how much do you need to be someone who actually understands and can relate to communities. And if that's the case, how much of that is part of your medical school entry, is that you actually represent and engage with communities versus being very, very good at your physics exams or whatever, I think another thing is again, how much time do we give to doctors to engage with communities? Or do we jam the way that we structure the financing of healthcare? Do we jam pack their day so much with their clinic visits that actually there's no part of their role, no part of their day that allows them to go out and engage and have those conversations? Many people would like to, and I think you get the doctors you train. And 10 years ago there was a big commission on transforming health professions in the 21st century, that said a lot of these things. They said we need to train health workers that are, in community-based leadership, and kind of cultural competency and flexibility and all of these things. And yet we go back to a medical training that is highly focused on science and on clinical delivery. So I think, the system will always deliver what it's designed to deliver. And at the moment, the system is designed to deliver elite doctors who stay in their clinics and don't get out. And inevitably, that's going to lead to a lack of trust. So I think, saying to doctors at this stage, well, it would be good for you to spend more time talking to people in your community, I think it's true. But I don't think we can put the blame on the individual doctor for why that's not taking place, because the whole system is not enabling or encouraging, doesn't value those activities. If anything, you're punished as a doctor for saying, I'm not going to do a clinic this afternoon, I'm going to go and have conversations with people. There's very few facilities that are progressive enough to enable that. So I think it kind of requires doctors and health professionals to reimagine their roles, but also patients and governments need to enable that environment to happen.
Um, Thank you. Yeah, it makes total sense. We need to transform those structures. And I think there's some people at ECV and Yaneer trying to work on that to what are the structures that we need to transform. There's another comment from Nikki. They live in New York City, and they tried to reach out to local politicians and had a bad experience. So they're saying that the local politician said she served the people and the people do not want to be educated in mask wearing. Do you have any thoughts for Nikki and how they can better approach their advocacy?
Yeah.
Yes, go ahead.
Thomas, I mean, I actually had a thought which I think relates to Nikki, but also Matty's earlier question about urban areas. I mean, I think I think that one of the things that happened in Sierra Leone was that in the early days of the crisis, the government gave grants to members of parliament to go and kind of sensitize communities on Ebola, which was a total disaster. And it became a big scandal because it was sort of seen that these MPs had, as we say in Sierra Leone, eaten the money, and and that nothing happened, and so on and so forth. But also, coming to Nikki's point, I mean, local politicians are not necessarily the best representatives. Sometimes they are, sometimes they're not. And I think the key point, which also relates to Maddie's question, is that who people talk to, who they spend time with, who they listen to, influences them, is always different, right? So what you have to do is try to sort of listen to people and ask them and find out where do they spend time, and who, and also who are the term natural leaders was also used in the chat there. Who are they kind of engaging with, and how is that communication taking place, coming back to what we said earlier about different ways of communication. And will look different. It could be sports clubs. What ended up happening in Sierra Leone was that the focus moved very much away from those sort of support to MPs and very much towards support to local chiefs, which was much more successful, especially when the chiefs were really kind of worked with very closely, so that they developed a good understanding, because of course they won't necessarily start with that. And also in urban areas, it varies, but in a lot of urban areas in African countries, you won't have local chiefs in the same way, because there will be more diverse communities, but you will still have different kinds of associations. So for example, in South Sudan, in urban areas, you have very active associations for the sort of ethnic group in a particular area where people have come from. So there'll be a kind of an association there. And if I'm a Dinka coming from more upstate, I will be able to find where my Warab Dinka colleagues are. So even sometimes in urban areas where things are less kind of, where geographical units are much more mixed, there are still those kind of associations, could be religious associations, whatever the case may be. But I guess the key point is that we need to sort of sit down and really, really understand what they are, and then try to work with them. So I haven't really come across sports clubs, because I haven't really, I suppose in African cities, people will pretty much all still know each other in my experience, but I know it's certainly very common in global cities that that's not the case. And so I think sports, religion, different kind of cultural, ethnic groups. But the point is, we will only find out if we listen, if we ask, and which, on how that's going to go. I just wanted to make one other point, just kind of following on from the earlier questions also about healthcare and so on. There was a quote, I think it was Raj Shah, who runs who's actually I think an academic doctor based in the US, but who also runs an NGO in Liberia, and he had to go before the U.S. Senate and talk about Ebola at some point. And he was asked, I think, by a senator, what is the best kind of, emergency healthcare system, for these infectious diseases. And he said something along the lines of, well, the best emergency healthcare system is a day-to-day non-emergency healthcare system that actually functions, which I think is something we all need to remember. And I think that the points, that have been made about the public health nursing system in New York on the chat, and the kind of innovations that Oliver was talking about. I mean, that's what will stand to you in emergency. In an emergency is the day-to-day stuff actually, functioning. And I know this is a huge issue here in Ireland, where I am at the moment, is getting healthcare much more, out into the community, much more community based. And then those same structures can be hugely useful when you have an emergency.
I have a couple of things to add. I do think that the framing that Oliver and now just Sinead has added about the importance for healthcare being community-based, geographically based, is somewhat a counter to this idea that we have all of these cross-cutting communities of sports clubs and associations and so on. I think the geography is super important. At the same time, there is this, different structure of the society, of networks that are in the community. And what we've seen is the disempowerment of the community and of the leadership of the community. And one of the key things in this context is to work, as I said, with the natural leaderships, but to empower them with the information that they need to work with their community. So just recently I spoke with a group of intentional communities. They're around the world, but in various places. And the point is that the people who are the natural leaders don't know that they have a role to play. They're not aware that this is an opportunity for their strengths to make a difference. And providing them with a few key pieces of information, clarity about the nature of disease transmission, which is not that, while you said earlier that it's not known, but we know the basic structure of it, right? We know enough about it. We know in details, but we know enough about it to act on it. And knowing what are the essential responsibilities, the essential actions that will lead to success, enables them to act. So this is where the information flow about, first of all, what is going on, what are the key abilities that are needed, and what is the execution that will lead to a successful outcome. That is super empowering because they have the ability to execute within their communities, or they can collaborate with others that have the ability to execute. So we need to give them that information.
Thank you. Yeah, thank you very much for those thoughts. I don't know, we can maybe wrap up with some last thoughts. Oliver, Sinead, and Yaneer. Shall we start with you, Oliver?
Yeah, sure. No, I mean, I think it's been a really interesting discussion, and I think the point I'd probably want to highlight most out of it is just how much we haven't been talking about medicine and how much we've been talking about communities and trust. And I just think that, but if you look at handbooks and guidelines, it focuses on pathways and processes, but actually we need to be talking about trust and communities much more, as we have in this conversation, and we need our kind of political leadership and our health leadership to engage so much more in that conversation. It's, outbreaks are spread by viruses, but they're social diseases. They are spread by social activity. They're spread by social norms. And that's far more where we need the expertise and the focus of the debate to be.
Sinead or Yaneer?
Yeah, I think just coming back to the point about, kind of the community health, I think, this expression, never waste a crisis is important as well. I mean, I think, COVID is, of course, an opportunity to do some things that, for whatever reason, are very difficult to do, either, politically, budget-wise, in normal times. And I think that's, that's got to be our focus, as well as obviously trying to respond to the crisis itself, is to try to see, what can be sort of pushed through, that, like a lot of these ideas about community healthcare that nobody really objects to, but they never really get the budget. They're not maybe so sexy in normal times, but I think, we would want to look back and say, well, we made use of the opportunities presented by this emergency to actually get some of that stuff through. But I think, really it is just, I think, to as Oliver said, we always say that there's 5 lessons in our book, but one of them is more important than all the rest of them, and that is the one about the community aspect of things. And I think it's really good that we're all, I think, kind of having the same orientation today, and that recognition, and it is so context specific, but I think the same principles of listening, and and being guided by what people at the community level say that they need, or think that they can do, and ways in which those of us involved in the response can help or not. I mean, some may not need any help at all, but I think it is that point about listening that is just preeminent. So thanks.
Thank you very much. Let's go with Yaneer.
So I just want to thank Sinead and Oliver, and the clarity of the discussion and the imperative that we are under. We really still continue in this context to have a tremendous challenge ahead of us. And the sooner we can apply the lessons that we've learned across context and across diseases to make things better, the quicker we'll get out of this one, and the better we'll be prepared, of course, for the next one. The reality is the teacher. We all learned these lessons not because we came with the idea of what was supposed to be the truth, but because we saw it in the context of the real action. And I think that message must be strengthened and inform the actions of people who are not as aware of the reality in the context of an outbreak, and as has been discussed, in the context of many other problems that we have to face in society. So let's do it. And thank you again super much for the presentation.
Thank you. Thank you very much. Thank you everyone for joining. You can find more details at endcoronavirus.org, or in Sinead and Oliver's book, Getting to Zero. Thank you so much for joining. This is very inspiring for someone trying to do some community action. And thank you all.
Take care.
Thanks so much.
Bye-bye.
Bye.